Good morning. I hope things are fine. And I have sent an email. You have this question everybody was asking. So probably that will be answering your questions, that how much has to be prepared and what is needed. Guys, exams are not something out of the world. It will be what we have learned so far. And be rest assured, those who are regular with their studies, I don't see any problem that they will be facing, inshallah. And we are not designing exams to fail people. People fail by their own mistakes. And exams are something they will tell you how and what to study and how you can be focused. I'm sure you learn from your experience from foundation, and now you'll have more learning, and inshallah, you'll be doing good. I'm very hopeful. I can see this class has something which is very good, very special, that is energy. And I can see people are interacting, people are bothered, and people are asking. Who's asking? The one who is bothered and the one who likes to do things. So I can see this class has some extra energy, mashallah, and I hope it should continue. So with this note, I like to start with our work for today. So Mice, I think I'm fine. On my computer. Okay, guys. So last time we were talking about the flexors of the forearm, and we talk about 3 layers. And we said there are a number of muscles who were present in the superficial layer. There was a muscle who was present in the intermediate layer, and there were muscles who were present in the deep layer. We talk about their nerve supplies, and we have looked into their actions, and I'm sure all of you have completed this cycle in the labs, and I'm sure you have seen all those structures, and I can see that I was there, not all the time, but a lot of time, and I was asking you guys, and I can see people were engaged in learning, and peer tutors were really doing their job. That's a good thing. So let's summarize. So this forearm, we all know that. I'm not bringing anything new. So the anterior compartment, on a short note, how I can summarize it? So the muscles are what? What are they doing? Wrist and the digit flexors, and they are pronators. This is what we have learned, and this is what we have said. And then their nerve was median nerve and its branches. Some of them were getting directly from the median nerve, and others were getting from its branch called anterior interosseous nerve. Are we good? Then we talk about the arteries who are responsible to supply in this compartment, and we can see that there is a significant contribution coming from both of these sources, the radial and ulnar arteries. And we all know what are they continuation of. We don't call them branches. Branches are which are given from them, but these are the continuation of the main artery. And who was the main artery? It was brachial artery. And brachial artery was continuation of subclavian artery, axillary artery. And axillary artery was continuation of subclavian, and subclavian was coming from the right, on the right side of my body, from the brachiocephalic trunk, and on the left side coming directly from the aorta. And aorta was coming from where? From the left ventricle of my heart. So this is how, that's the backward journey, and you are expected to be good all the times. Now, the anterior compartment, we have, for our understanding, I'm sure when you have been to those cadavers, you have not seen any compartments. There are no boundaries but for our understanding. So we divided them into superficial layer, and there we were learning about 4 muscles. And we have seen majority of them, they were innervated by median nerve through its muscular branches. And there was one exception, and that exception was innervated by the ulnar nerve, the muscular branch of the ulnar nerve, and that muscle was flexor carpi ulnaris. Then we talk about the middle ear, and the middle ear muscle, this is the one which is flexor digitorum superficialis, which goes to the phalangeal levels. But it ends at the base of the second phalanx. We all know my digits, digit 1 don't have 3, but 2, 3, 4, 5 all have 3 phalanges. And we call them P1, P2, P3. Then this is the middle ear muscle, and the last deepermost layer, we learned 3 muscles there, and those muscles were flexor digitorum profundus, that was going to my distal phalanges, pronator quadratus, that was attached at the lower end of radius and ulna, it binds them together. When we are doing push-ups, at that time, our radius and ulna kept in their position, they are not being detached because the big force is applied on our hands. So at that time, these bones has been kept in their proper position. And the last muscle we learned was flexor pollicis longus, and that was the muscle which is responsible to control my first digit, my thumb. The thumb, we call it pollicis. In my foot, big toe, we call it hallucis. We will be learning that, don't worry, after midterm, inshallah. So this was the summary of what we have learned 50 years back. So now, there is something for you. What do you see in this picture? I cannot hear you. One person. Say it. She can see carpal bone. Can you see something else? Nerves and muscles. Any other word? Carpal tunnel. Wow. Yeah, you're right. Noor, what do you think? Yes, you're right. Guys, a simple thing. Learn to say simple things. It's a cut hand. A hand which is cut, and then this hand has bones, arteries, muscles, nerves, veins, blah, blah. Everything is there. From skin to the bone end. Are we good? And the next picture is labeling. So all answers which have came from you, they were all correct. Somebody said there is carpal tunnel. Who said the term carpal tunnel? Okay, can you elaborate your term? What is carpal tunnel? Okay, it's fine. It's okay. But at least you know something. I'm glad. That's what I said in the beginning. People are putting efforts. Guys, you come step forward, will take you through rest of the journey. But you have to take your step. Okay, so now being focusing on that, what we were seeing in the previous image, and there I'm showing you, this is a section. We all know the carpal bones, they are 8 in number, and they are arranged in 2 rows. So we can section at the proximal row or a distal row, doesn't matter. I know after presenting this slide, my inbox will be full. Doctor, my book says this and your presentation says this. Guys, there are 2 layers. You cut before or you cut after. Doesn't matter. So now, let's label it. Let's see what it is. This is the same cut section which we have seen before. But now you can say more. I can see the carpal bones. Your answer is more meaningful. I can see carpal tunnel. Your answer is more meaningful because we are zooming in. We are going inside. The previous picture was a broad image. So what are we doing here? So let's name the bones. So my number 1 bone is the hamate bone. These are the names of the carpal bones. And unfortunately, you need to know them. Then we have the capitate, trapezoid, and trapezium bones. This is one layer. Another layer, you cut it, the names will be changed. So these are the names of these bones which has been shown in this image. Going further, now I can see all the tendons. Tendons where? On the posterior side, all the extensor tendons have been visible to you. We didn't talk about it. So they are outside my tunnel. You can all see there is a tunnel. Where is the tunnel? There you go. There is something, a bridge, and this brownish thing is the tunnel. And on the base, I have these carpal bones. Are we good? So now, these are the long extensor tendons, which are crossing. If I see on the dorsal surface of my hand, you can see there are so many tendons which are visible to you. If you stretch your hand like that, you can see they become visible to you. So these are those tendons. And now let's start filling this carpal tunnel. So someone very close to my trapezium bone. So all of them are the tendons. And that one is flexor carpi radialis tendon. We all know the flexor carpi radialis muscle was one of the superficial layer muscle, and that was coming from my common flexor origin, and that was coming to the radial side, to the base of my second digit. That's the place where it was attached. So this is my flexor carpi radialis, because this section, this is somewhere here. I'm cutting somewhere here. Now there is somebody else, an artery. Someone was asking me yesterday night around 1:30, which artery nurse palpate, brachial artery or radial artery? So I write radial. So this is the same, but this is not the radial artery. Don't get confused. Don't get deceived if anything is red is an artery. Artery have to have a lumen. So that is my tendon of flexor pollicis longus muscle. Why I make it red? Just to distinguish it from the others. So now there are certain labels who are coming in boxes, and there are certain muscles who are not present in boxes. So that you have to focus on. So the labels in the boxes denote structure passing through the carpal tunnel. So if somebody asks you, who passes through my carpal tunnel? So who's in box? I'm showing you two muscles here. One is without a box and one is in a box. So inside the box is my flexor pollicis longus tendon. So that is in the carpal tunnel. Now, can you see these four tendons? Two on top, two on bottom. This is the classic representation of flexor digitorum superficialis. The tendons does not go like this. Two on top, two on bottom. But the profundus tendon, they go like this. And this is how we differentiate them on a section. And then, so these are my flexor digitorum superficialis muscle. Muscle becomes tendon, so tendons are visible to us. Are we good? Now, in the bottom, deeper to it, you can see four in a row. And these are my flexor digitorum profundus tendon. I'm sure everybody is good with these names because we have learned in the beginning of this week. So now, after this, can you see that? What has been added? Something has been added which is separating these tendons. It is providing, facilitating their movements by some compartmentalization. Lubricants, we will be seeing in the other picture. How is that? But you can see all these muscle tendons has been compartmentalized. On top of the story, two tendons of superficialis, there is something underneath. Then two tendons of superficialis, and then there is some cushion, some pad. And in the bottom, four tendons. And below to them, there is another cushion. So basically what happens? We are performing how many times? Can you tell me how many times you flex your digits? It's a countless. You're sleeping, you're doing it. You're awake, you're doing it. So we don't have a number. So did you ever heard a sound? You know, you open a door, if the lubricant is gone, when you open a door, you can hear a weird sound. And then you have to lube in, and then the sound goes away. But we are blessed. We are made like that. We don't need any extra lubings. So this is something, and what is that called? That structure. So we call it ulnar bursa. And primarily, we all are familiar with the term bursa. It's not new. Ulnar, it's on ulnar side. Make sense? Because we all know that where is radial side and where is ulnar side. Towards my hamate is ulnar side. Towards my trapezium is radial side. Are we good? So this is called ulnar bursa or common synovial sheath. And what is the job of this? I have mentioned it already. It is basically facilitating the free movement. It provides a freedom of movement without, I'm not saying without, with minimal friction. Okay? So now, something new has come, which is yellow in color. Can you see in the image? That is someone for whom all this setup has been made. And who's that? That's my median nerve. That's a special guest here. So now, what's the story? Why we call it carpal tunnel? So, can you see that? There is something grayish added on top of these structures. And that grayish thing, we give it a name and we call it flexor retinaculum. It has another name, volar carpal ligament. If you want to make your life complicated, remember that. I love saying flexor retinaculum because it's easy to remember. It's flexor side and it's a band-like thing. You know, we are wearing bracelets, watches, friendship bands, so they are covering. And their job is what? To keep structures within their place. That is a modification in the deep fascia. It's become thick in this pertinent part, connecting between my hamate and my trapezium bone. It's a bridge that completes, that makes it, it's a tunnel. Above to it, this patchy work is the superficial fascia, and the outermost brownish core is the skin. Are we good? Okay. Now what happens? We are set so far. So now look at it. Above to this retinaculum, I have brought two structures. And what are these structures? One is red and one is yellow. Who are they? They are median nerve, its palmar cutaneous branch. So median nerve, before entering this tunnel, it gives a sensory branch. That supplies where? Skin of my palm. Skin of my palm is innervated by this palmar cutaneous branch of the median nerve. Are we good? So this branch is given by the median nerve before entering into this tunnel. This is a really important branch. We'll be using it for some really important purpose. Okay, now you can see on the ulnar side, near to this hamate bone, I have brought up a yellow thing and a red thing. We all talk about this is ulnar side. So these should be my ulnar artery and ulnar nerve. Are we good so far? Any ambiguity, anything new, any rocket science? Okay. Now what happened? Unfortunately, there is a problem. This affects mostly the females. Males are also affected, but their number is less. Females are affected more. And different times of their life. Not necessarily everybody, but a big number. During their pregnancy, their lifestyle, other issues, some underlying problems, it's become very painful. If somebody is a secretary in an office, she is finding so difficult using that hand for typing. If it's a house lady, she cannot do household work. the cup of coffee, glass, things starts dropping. It's become very painful. More she work, worse it is. What happened? Have you anybody sitting here experienced that? No. I can see a big no. I know there is someone in your class. He was, I was mentioning that in the evening lab, and he said, look, I have this carpal tunnel. I don't want to name him. He knows, he's listening to me, I'm sure. He's one of those who's awake. So, now on the radial side, I have added up something more, and that is my recurrent radial artery. We talk about that. Now, what is that? An ovoid structure on the flexor side. That's the tendon of my palmaris longus muscle. We talk about this muscle. It is absent around 25% of people, and this muscle is not going to any bone. It's been attached to the palmar aponeurosis. Your palmar creases where people look at your fate on these lines. I wonder. So this is the tendon of palmaris longus muscle, and that is the one who stretches my palmar aponeurosis, keeping it tight, stretched. Now what happens? In carpal tunnel situation, this is a normal situation so far. So those who are affected, now focus where? Focus in this central part. What happens? Can you see that? Suddenly, the space is being filled by something. Let me do it again for you. Just stay focused. Around the tendon of superficialis profundus, under the flexor retinaculum, look what happens. This space is filled. Now this space is filled with a fluid. This fluid be of any nature. We are not going into. This space is filled. Now, this room is designed, where you are sitting, designed to accommodate 156 students. If I bring here in this room 2056 students, think of it, and everybody wants to sit down. What will happen? Kind of a stampede. Those who are in center, they might be crushed. Or something, maybe some reptile appears. You got panicky, you start running, you don't care. And there can be a stampede. Things can be crushed. This room will be congested. So when this fluid is being filled up in this space, space become tight. Tight on all these tendons. But tendons can bear with this. But the median nerve, who is inside? There's only one structure who was inside from the neurovascular character. There is no artery inside. If there was an artery, it could have a blockade. So this nerve can be compressed. Now, more you move your hand, more pain is there. If you are typing, more you do, you start your work, there's less pain. But you have to finish the task. You have to complete your, let's say you're taking your MSK final exam, and you have to write blah, 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 blah. So it's 2-hour show. So more you work, this pain gets severe. A time reaches, oh, I cannot do it. You are doing some job, you are busy in your kitchen, you are busy in your home for doing something. So more you move, the pain gets worse because the space becomes narrow. Are we good? So that situation, when this carpal tunnel is filled with a fluid, that time it is called as carpal tunnel syndrome. And what is the treatment? Maybe you take a pill, it helps you, but that's not the answer. You have to go for a surgery. Lifestyle modification, there are designed different type of keyboards, they are designed for these people. It can facilitate. There are so many splintages, so many other things. They are good for initial stage of the disease. But once it's getting worse and worse, it's a very simple surgery. What is needed? Just split this flexor retinaculum. Just make a cut in that. Cut the skin, but please don't do it. You have to be trained. So cut the skin and just cut the flexor retinaculum, then sew the skin. Now, flexor retinaculum, which was the binding factor, On all other sides, there were bones, so you cannot remove a bone. So you cut this fibrous tissue thing, split it in the middle. Now this band, which was tight, you split it. So now this band is open. You have not removed the disease itself. The fluid may come, other things may come, but now this median nerve will not be trapped. So the mechanism is what? Median nerve. Which anatomical structure? Median nerve is entrapped, compressed. So many terms can be used. Impingement. All these terms are denoting to one common point. Are we good? So that you need to be very clear. So carpal tunnel is all about this. I have told you how it begins, who are the people who are more prone, what are the anatomical factors, what is the construction of this carpal tunnel, and what is the treatment. But remember, not everybody needs a surgery. There are so many people can be benefited with the lifestyle modification, but ultimate is surgery. So one can plan. It's not something, nobody will die of this. Be rest assured. Okay, going further. So now, median nerve being compressed by the fluid which is being built up, we talk about that. So now this is the same image, same concept. What you're looking at on the top of this, you can see the two levels. We were talking here. But if you cut it here, you can also see there is my retinaculum is there. Oh no, it's not retinaculum, the flexor retinaculum, that is there. And you can see there is a separate compartment which has been shown, and that is separating my tendon of flexor carpi radialis. That's not inside. So you can see on top the two level of sections. We can cut carpal at A level or at the next level, and down is the same thing. It's more big image just to show you inside. Are we good? No. Osteoarthritis is a disease of the joints. And osteoarthritis is the disease of my big joints of my body, not small joints. Small joints, rheumatoid arthritis. Big joints, osteoarthritis. What are the big joints? Your knee joint, your hip joint. These are the big joints. Okay? And rheumatoid arthritis is the disease of small joints. And where are the small joints? You can see in your digits. Not only in your digits, your neck, your foot. So many places you have the small, the rheumatoid arthritis. We are not talking here at the moment rheumatoid arthritis. Okay? So osteo, the term osteoarthritis, osteo, it's going to the bone. Arthritis, inflammation. Thank you very much. I love your answer. Okay, are we good? Now, what is this? Really? You look at it and you call it compartment syndrome? What happened? The story is, someone got some burn. Now we all know the limb, maybe upper limb, maybe lower limb, maybe my abdomen. It's wrapped in what? Outermost is skin. Under the skin, I have superficial fascia. Superficial fascia is a bit loose, but the deep fascia is very tight, very strong. So, if someone has a burn, after burn, what happens? Things start swelling up. So this swelling, same concept. So the structures inside, the trapped thing will become compressed. It can be in forearm. So deep fascia is enclosing all these, my flexor muscles and extensor muscles. And in between we have neurovascular bundle. So if there is a burn, if someone is putting a plaster cast, I'm sure everybody knows a plaster cast. You fracture your bone, you visit the doctor, they put a plaster. No matter it's a gypsum or it's a plastic or it's any synthetic thing, but all of them are called plaster cast. So this cast, if somebody is very fancy, putting so tight, the first thing we always tell our patients, After applying this cast, you are going home. If you feel your finger starts getting blue, if you have too much pain, I'm talking about forearm. If you have too much pain, don't do anything other than rush back to hospital, your nearest hospital. Don't hunt for me. Go to your nearest hospital and ask them, please cut it. Because somebody has applied this plaster cast too tight. After trauma, after fracture, there is swelling. After burn is also a trauma. There is a swelling. But in burn, we don't apply the plaster cast. I'm talking about normal fracture treatment. No matter you do a surgery or you do a, in just close reduction, they apply a cast. I posted this question and I'm still waiting for the answer. Half of the answer has come, half of the answer is yet to come. You have to work on that. So now the treatment is split this. When you split this, there is a room for expansion. But if it's a burn, now the deep fascia encloses all around my flexor compartment muscles, my extensor compartment muscles, and my flexor compartment muscles. In between, we have neurovascular bundle. So everything will be trapped. So this, what is being trapped, it's become an emergency. Now, rush this patient to a hospital. After evaluation, not like everybody can do it. No, don't try it at home. So you rush this hospital, experts can see that, and if there's a need, what they have done, they have splitted the skin right away, an incision, and this incision is deep enough that it have cut the deep fascia. So now the compartment is being opened. So now muscles are relaxed and the neurovascular bundle, which was compromised. What are the signs of compromise? I can see my hand starts becoming pale. Pulses are getting absent. And a time reaches when it turns blue and black and end of the story. If you don't intervene, gangrene, then the recommendation is chop it off. No other solution. So this is the treatment. You split the skin. And somebody very nicely said it's a compartment syndrome. You can see an example of the forearm of someone, and this is after getting this. Now look at it. That was the initial picture. So the deep fascia has been cut, and you can see muscles are popping out of this wound. Are we good? So we call it compartment syndrome. Causes, I talked about fracture treatments, badly bruised muscles, there is some severe trauma, muscles go under injury and they can swell up. There's a natural tendency, and then there is crush injuries. So there are so many examples. Good for you, learn burns and fracture after fracture treatment with the plaster cast and such things. Are we good? So now this is how it's been taken care for. And now these are the causes, and if you want to go in details of it, it's written for you. Are we good? But this is an important, so we were talking about what? Entrapment. My previous slide, I was talking about carpal tunnel syndrome. Now I'm talking about compartment syndrome. So that is also a kind of compartment, but that was a small segment, and it's a big segment. Are we good? So the purpose is why we are learning this, so we should have some sense. We should have some application. We are not living 1,000 years back. We are not in Stone Age. We are, and I am interested that you should be doctor for tomorrow, not for Stone Age. Okay, so after giving that, we don't leave this wound open, but we apply a very special type of sutures. Can you see that? This is some elastic blue thing. So this has been, wound is not completely closed, partially closed. So it can accommodate. If there is a swelling, it can spread and it can, then otherwise it can slowly go back, and then we do. I'm not talking about the treatment plans, just to show you how we handle these people. Now this is a device when we are suspecting some rise in pressure. So it's not blindly. There is nothing in medicine which, oh, I have an experience, I have expertise. Excuse me, there is nothing called expertise. It's what? Do you have an evidence? If you are cutting someone's forearm, you should show an evidence. So this machine can gauge the pressure. It can tell you how much is the pressure inside that compartment, and there are certain cutoff values. Please don't go in these details. This slide is just for seeing, not for reading, not for Googling back. There are so many gadgets, it's one of those. Are we good? So now, to summarize, in the flexor compartment, we have a number of muscles. We know about them. We have arteries, we talk about them. And then we have nerves, we talk about them. And which nerve is supplying these muscles, it has been mentioned clearly. You have been explained. The main player, the nerves of my flexor compartment are median nerve and ulnar nerve. Ulnar nerve only deal with the two things. And what are those two things? Flexor carpi ulnaris and the medial half, the digit 4 and 5 of my flexor digitorum profundus. So half of my profundus is innervated by deep branch of median nerve, and the remaining half is innervated by a muscular branch of ulnar nerve. Are we good so far? Okay. So guys, we are done with first part, what we have to cover on that day. So we are done with that. So now, today I have brought up an activity. So let's see what we were talking, how far you are connected. Okay guys, I'm throwing a pool here. Is it visible in your devices? Why? On. Turn it on. Your batchmates are answering it. Let me read it for you, those who are struggling with their Zoom thing. Which of the following nerve is trapped in carpal tunnel? So it's a multiple choice, and the choices are ulnar nerve, median nerve, recurrent branch of the median nerve, anterior interosseous nerve, posterior interosseous nerve, radial nerve. So these are the options. Okay, so I can see that. So I'm just waiting people to finish. Around 135 people have participated so far out of you 425. So 375 people are present at the moment out of 425. And out of those, I can say around 200 has participated, and about 100 and plus people have just turned on their devices and they are probably sleeping or doing their breakfast or doing some other important works which are more important. I can see that because they are not responding to this activity. Guys, hurry up. In 1 minute, I'll be ending this pool. Guys, you will not get this much time in your exam. The allotted time is 60 to 80 seconds. And people have consumed 3 minutes, 56 seconds so far. So now let me tell you what people have chosen. The option for ulnar nerve, 9% of the class, 227 has participated so far. So 21 student has chosen the option ulnar nerve. Recurrent branch of the median nerve, 12 out of 229 has chosen 5%. Anterior interosseous nerve, 2% of the students. Posterior interosseous nerve, 1%. Interesting. And the radial nerve, 5%, that means that 12 students. So 230 people had participated. And the option for median nerve, 91% people has chosen this option as the right option, and their number is 210 out of 230 who are participating at the moment. Okay, so now I'm ending this poll from here. So you can see the results. Can you all see the right option and the wrong options and how it has been spread for your colleagues? So this tells us what we are learning, how far it's good. Okay. So now let's proceed further. So now today's topic is extensors of the forearm. And you can see the things which have been shown in this image in brown. Those are the extensors. And those who are in blue, they were the flexors. These are the objectives. Okay guys, now I have started one more strategy because the time constrictions. I have designed my synchronous lectures and asynchronous lectures. Asynchronous lectures are recorded and they will be present on the Moodle. They will help you in deep understanding. So you can, because of the time constraint, I may not be talking in detail about those topics, but if you want to listen to me with the slides and with the voice, you can just go over with those things, and that will be a resource for your further help. Okay? So there are certain lectures, like the major concept will be in synchronous. This is synchronous. Maybe you are sitting here or you're sitting at home, we are connected. But asynchronous, everything is done, you're not there, but you can listen to it like the same what you're listening. If you're listening my recording, you can see that. So now, to start with, this is not new, same old story. I don't want to spend time on that. We talked about this before. We have said anterior compartment, its nerve, further compartmentalization, same concept. So this much has been done. Now coming to let's talk about the posterior compartment. So these muscles they extend what? Wrist and digits, and they are helping in supination. And their nerve is posterior interosseous nerve. Guys, posterior interosseous nerve is a deep branch of my radial nerve. A general rule, all the posterior compartment muscles of my arm and forearm, their nerve supply is coming from radial nerve, directly or through its branches. Are we clear? And the anterior compartment in the arm, the nerve was musculocutaneous. And in the forearm, the nerve was median and its branches. Okay, so let's proceed further. This is what we are looking at, a real image of an extensor compartment of the forearm, and you're looking all the muscle in place. Now, let's begin the story. We are good with these bones. You're looking at the radius ulna with an interosseous membrane and lower part of the humerus and the whole of the superficial layer. Again, we learn things superficial, deep, same concept. So superficial layer. Guys, we talk about in the previous session, common medial epicondyle, site for flexors. Now lateral epicondyle, it is a site for extensors. So majority of my extensors, they are coming from lateral condyle, lateral epicondyle, and my flexors were coming from medial epicondyle. So learn this. We talk about golfer elbow, tennis elbow. So those who are playing tennis, this is involved more. Now let's put the layer by concept. So now this is my common extensor origin tendon, this gray thing. And then I have a muscle, which is going to my digit number 4, base of my metacarpal of my digit number 4. Who that muscle should be? Radial side. Flexor carpi radialis longus. Extensor, thank you. Extensor carpi radialis longus. And it's not getting through posterior interosseous nerve, it is getting through radial nerve. Its nerve supply is coming through radial nerve. Then a small one is called extensor carpi radialis brevis. Longus means long, brevis means short. You can see them. They are side by side. And that is going to the base of which metacarpal? Thank you. And then this huge thing, extensor digitorum. I don't have superficialis and deep. It goes all the way down to the distal phalanx. It also attaches to the middle phalanx. Are we good? These are extensor hoods. We'll talk about them in lecture number 15 when I'll be explaining in detail about hand. Guys, that will be a rich lecture. Too much energy is required. So come with good breakfast, good mental health, a big cup of coffee. So these are dorsal digital expansions. They are helpful in accommodating these tendons and bringing certain movements. We'll talk about that mechanism, not today. Now a small one going towards my pinky. Extensor digiti minimi. The scientific name, anatomical name of my pinky is digiti minimi, a minimal digit. Extensor digiti minimi. And then last, I have extensor carpi ulnaris. Mashallah, you guys are smart. Are we good? So these are the muscles of superficial layer. Guys, on purpose, I have not included brachioradialis here. Before talking of extensor carpi radialis longus, the first tendon which is there, because I'm taking all of them from common extensor origin. And my brachioradialis is coming from the humerus, supracondylar line. So that will be more on lateral side, more on radial side. Are we good? Now, this is a small muscle. Think, very tiny muscle, enconius. You'll try to find it on cadaver, you'll be struggling. Injury to my common extensor origin, we call it tennis elbow. Right? So all my extension movements will become painful. Guys, I remember the batch who is now in final year. When they were in MSK, one of their SAQ question was on common extensor tendon origin, and a significant number of those were not able to convert this question right. And they had quite a lot, there were quite a lot of discussions. So please stay connected with the things. Don't ignore things. And this was a simple tennis elbow case. There was no rocket science. Okay, so these muscles, we talk about them, what they are doing. So you can read it. I need not to read the text. We all know they are extensors of what? Wrist and digits. Those who crosses a joint, they will bring further, and those who are just crossing the wrist joint, they will be bringing extension at that part, and those who crosses go over, they bring extension of wrist plus digits. Remember that. If a muscle crosses two joints, it will bring that action on two joints. If I ask you, okay, I'll post it on your discussion forum, that question which is in my mind, I'll post it there. Okay, so now you are looking at what we have talked so far. You can see that the muscles, we didn't talk about those who are going transversely, whose are radiating out, but the others we talk about. I'm not talking about these three, but we have talked about, you can see the brachioradialis, extensor carpus longus brevis, extensor digitorum longus brevis. We have seen the extensor digitorum, extensor digiti minimi and conius. All this we have seen. Okay, so now we are done with the superficial layer. We know their nerve supply. Are we good? Now, the deep layer. A muscle. Who is this? Supinator. A muscle whose supinator is not the chief supinator. The muscle whose bicep brachii is the chief supinator of my elbow joint. Second major supinator, a nerve going so close to it. Who's that? Radial nerve. So here it splits. You're looking at a superficial branch. So radial nerve, when it reaches to the elbow joint, it divides into a superficial branch and a deep branch. The deep branch, superficial branch has to do very little about muscular supply. But the deep branch is named as posterior interosseous nerve, and that is the responsible factor. You can see that it goes through it, it pierces it. So rule says a nerve who pierces a muscle must supply that muscle. Not passing between, piercing. If someone has two heads, someone goes like that, it's not piercing. But if someone is puncturing it, going through and through, that is given that name. So now this is a deep branch of my radial nerve. And this muscle, we talk about it. Look at this muscle, which is going to my thumb, coming from interosseous membrane. This is my abductor pollicis longus. We have only one flexor for the thumb, but we have so many on the extensor side. So we have abductor pollicis longus. Then who's this? Look at it. You can identify these muscles on the basis of their distal attachment, because on top they all have mixed with each other. So one which is going to the base of my metacarpal, that one is my abductor pollicis longus. And the one which is going to the base of my proximal phalanx, that is my extensor pollicis brevis. And there is one long one that is going to my distal phalanx. That should be my extensor pollicis longus. Guys, we need to be good with these muscles and tendons of the thumb, because it has a clinical relevance and we love to ask them a lot. Are we good so far? So primarily, these muscles, abductor pollicis, extensor longus and brevis, they are helping what? They are helpful in movement of my thumb. Movement of thumb are a little tricky, but I'm not talking today. Now there is one more. That is, this is one of the strongest finger. You are angry? You say you. And this finger is really useful. In some surgeries, the whole operation is done by this finger. In old days, when we were doing prostate removal, this finger was used. And surgeon used to take out the whole prostate by just manipulating his finger. Nowadays, it's all in the urology, so that era is gone, but still, there are cases. So this finger is controlled by a very special muscle. This is my index finger. So this is an extensor. We can name it extensor indicis. An extensor for my index. So I need a very strong and extra strength for this finger, because I'm using it a lot for so many enucleations. Are we good so far? So now we are looking at what I'm showing you. Posterior interosseous nerve and posterior interosseous artery. Just recap, my ulnar artery, when it reaches to the proximal part near the elbow joint, it gives common interosseous artery. Common interosseous artery divided in two. One goes anterior, we call it anterior interosseous artery. That was supplying my flexor compartment. The one which goes behind, that is called posterior interosseous artery. And that is supplying my extensor compartment of the forearm. Are we good? Thank you. So now, the same thing which I have talked about. Now, look at it. We will use a term, I don't know if you can see from there, but you can see in your own hand. If you do like that, if you stretch your thumb like this, you can see there's a dip form, and that is called anatomical snuff box. And this is used for not a good purpose. Mukhaddarat. People say for perfume. I don't know who need to put perfume in this fossa. You can put perfume anywhere. Why you need a dip in this place? Are we good? So now we can see in the dissected model, and there you're looking at the same stuff, the tendons. So this is the anatomical snuff box, but you need to be good at it. You need to be knowing its boundaries, who's making what, and its content, and who are the structures. So this is shortly, because Dr. Jabbar is here, but still I can tell you exactly. I have 4 minutes. So this bone, scaphoid. Guys, scaphoid is one of the very important bone out of my carpals. Most commonly fractured carpal bone is scaphoid. Most commonly dislocated carpal bone is lunate. This is rule of thumb. I'm not saying others are not fractured. Most common. So now, these are my muscles of the hand. We didn't talk about them. These are the dorsal interossei. And this is a tendon. We just talk about the one who goes to the base. Who was that? Extensor, pollicis, longus. Excellent. You guys are smart. And then we see someone who goes to the base of the proximal phalanx, and that was my extensor, pollicis brevis, and this one, abductor, pollicis longus. So you can see the boundaries, and there is the radial arteries going through that, passing through that. It pierces my first dorsal interossei to reach to the palmar surface of my hand, to enter there. And then a vein, which vein it should be? Cephalic vein. It goes in the roof. It's not the content. Content is only one. That is radial artery. And then there's a nerve. This is the superficial branch from the radial nerve. Are we good? So guys, I'm stopping here. And I'm left with only one slide, but it's okay. So, on a quick note, I know. Fine, I think it's good for today. Okay, guys. So for your question, we can talk our usual way. I can stop recording. Is already stopped? Perfect. And from here.